Welcome to everyone who's joined us on the Friday ICM teaching, which is cross-site. Today's topic is going to be quite interesting and useful to most of us. It's on approach to ventilation in intensive care. Dr. Fran Tate, who is one of the senior trainees in anesthesia and ICM, is going to deliver this talk to us. Over to you, Fran.
Good afternoon, everybody. My name is Fran, and I'm a dual specialty trainee in anaesthesia and intensive care. I've just rotated out of Leicester Royal ICU and just doing my neuroanaesthesia module at Queen's at the moment. This is a pretty open-ended topic, and because I think we're near to the beginning of a new rotation, I've kind of directed it at the basics and a bit of background on why we do what we do, rather than a deep dive into respiratory physiology. So aims of the talk are to cover some basics of ventilation on ICU, demystify some of the numbers and abbreviations that you might see, give some background to our target parameters, so as I said, why we do what we do. And I wouldn't describe myself as especially academic, so I think next week Dr. Matt Charlton is doing a talk, and I've got it on good authority that Matt once read West's respiratory physiology from cover to cover for fun. So I think you'll maybe get more of an academic slant from his talk, but mine is going to be an introduction really. But first, I did ask permission before I do this. I wanted to just give some shameless plugs to some stuff that I'm involved in. So I want to just briefly talk about the Intensive Care Society. I am the Vice Chair of the Intensive Care Society Trainee Advisory Group, one of 7 professional advisory groups that feed into Council of the Intensive Care Society and try to help shape their strategic aims as a charity. Their website contains lots of useful guidelines and information, as well as educational events and support. And I'm involved in organising sessions at the State of the Art meeting this year, which is in Belfast. And if you scan the QR codes on the next couple of pages, it will take you to hopefully the instructions and guidelines for submitting abstracts. And the first session I just want to plug is for any doctor who's not a consultant working within intensive care from sort of foundation upwards. And the brief for this is to kind of rewrite the training programme, but better. So there's been a few issues over the last few months plus with intensive care training, specifically the exam, and people maybe have got some frustrations with the pathway. So it's actually saying, OK, well, come on, why don't you write what you how you think it should be? And then the top presentations or the top abstracts will be invited to talk at State of the Art and kind of defend why they think that their idea is better than the status quo at the moment. So that's called the Cauldron. And then the second session I want to publicise is called MDT Diaries, and anybody on the intensive care team can submit to this. The brief is a day that changed my practice, and it's basically a reflective account of something that really impacted the way you practice medicine and within intensive care. Last year I was involved in sort of marking the submissions, and they range from sort of team submissions with how it was quite COVID centric, some of it, but how a team had adapted to work because of COVID and how it had changed their practice going forward. And then to somebody wrote a poem about how a day had changed their practice and everything in between. And then the top abstracts get selected for presentation at the conference in that session. And really, we would really like to hear from everybody, and I'd really like it if people from the East Midlands, Leicester were represented here, because I think it's a great opportunity. And the last one is called the ABC of ICM, and this was the most attended session at the State of the Art meeting in December. We're asking people to submit video abstracts and really senior trainees, consultants, specialty doctors, and all allied healthcare professionals who've got a special interest topic or an expert topic to submit around a 10-minute video recording of their talk, and then the top 10 will be selected for live presentation on the main stage at the conference. So if you've got something you'd really like to talk about, then message me for further details, and look out because I might be approaching you to talk about something as well. So there's something for everyone. It's going to be in Belfast. I first face-to-face conference for a couple of years because of the pandemic, and it should be good. And I would encourage people to think about submitting abstracts for it. Okay, so further info, website, my email address, and then now speak up if you want to ask me anything now about it before we go into the main body of the talk. I'll just give people a couple of seconds. Deafening silence. Okay, so I'm going to cover the basics of ventilation for people really who are not that familiar with it, and then maybe a little bit of background about why we do what we do. So here's a selection of ventilators, some of which you might see at the Royal or elsewhere. We've got a Draeger ventilator here. This is a GE ventilator. This is a Hamilton transport ventilator. We've got an Oxylog 3000, which is a commonly used transport ventilator. And then this PowerPack ventilator, which I think we've got a PD pack or variation of in the Peas Bay in Resus in ED for little kiddies. And the Hamilton ventilator we've got as an MRI compatible one. But they're all very different looking, but fundamentally pretty similar. So first of all, why do we ventilate people? I've got some clues on the screen here, and there'll be extra credit for anyone who can guess who the chap in the bottom right corner is in the black and white photo. But can people just say some reasons why we might intubate and ventilate people?
We had hypoxia.
Good guess. Okay. Yeah. And any guesses who this person is?
Is it Mr. Hamilton?
No.
Oh, Draeger?
No.
What's that?
General Electric.
No, so this is Georges Guillan, who is a French neurologist who in 1916, with two others, described two cases in soldiers of a self-limiting acute paralysis, which was associated with increased protein in CSF with a normal cell count. So that's kind of supposedly the demonstration of kind of a weakness requiring ventilation. We've got a kind of intoxication for so airway, breathing, maybe circulation, surgery, CNS depression, neuromuscular weakness as just a starter. And then by what means, this is not a quiz, so some surprisingly well young people there wearing face masks, so we can ventilate people through a face mask. This is a CPAP hood, next picture. That person looks about as happy as our patients do wearing CPAP hoods. ET tube, tracheostomy tube, and the man at the bottom is wearing a sort of modern version of an iron lung or a negative pressure ventilation system, but that's not really used widely on intensive care. So I thought maybe some background stats. So how many people do we ventilate and for how long? The website that used to publish this adult critical care beds has stopped publishing them as far as I could see, but from this is from January 2020, pre-pandemic, we've got about 4,000 critical care beds, much less paediatric beds, some bit more critical care for neonates, and our occupancy was about 80%. And about 100,000 patients a year are admitted to intensive care for mechanical ventilation through those 4,000 beds. The winter is obviously much busier because of seasonal respiratory illness. The pandemic's changed the game a bit with that. And patients who are ventilated, they spend an average of about 8 days ventilated. Once somebody is ventilated, how must we monitor them? And this is from the guidelines for the provision of intensive care services, which is a pretty comprehensive sort of set of things that we should do to look after our patients. So end-tidal CO2 capnography is a waveform trace of the exhaled CO2, and it sort of gives constant feedback that there is air travelling from the lungs out of the patient, so kind of implying that the tube or tracheostomy is patent. Saturations, oxygen saturation monitoring. The bedside nurse, I think, is pretty essential. ECG blood pressure, ventilator alarm set to appropriate parameters and loud enough to be heard, and access to point of care blood gas analysis. Just a little kind of backtrack into primary FRCA and what we're going to be talking about when I'm going to be talking about tidal volume. So these 4 small peaks are tidal volume breaths or tidal breaths. Then a big inhalation is your inspiratory reserve volume, and exhalation is your expiratory reserve volume, and they sum together to make your vital capacity. So to put mechanical ventilation into context, so during quiet breathing at rest, descent of the diaphragm and expansion of the thoracic cage generates around -5 centimeters of water of sort of negative pressure to draw in air. Positive pressure ventilation, as the name suggests, it's all involved, whatever mechanism you're going to use, involve unphysiological application of positive pressure to the lung. And up to about 30 centimeters of water is our inspiratory pressure, or possibly more, and historically more. So ventilation, it can be invasive or non-invasive, spontaneous or mandatory modes, or a mix of both. And I'll cover them all in a little bit of detail, but with more focus on invasive ventilation, because that's more of our USP in intensive care. So a mechanism, all conventional mechanical ventilation has a similar basic mechanism. A fan within the box there pushes humidified air, often it's humidified via a humidifier that you'll see attached to the base of the ventilator unit there. And then there's passive exhalation, and it can be pressure or volume controlled. And there is an overwhelming number of different acronyms, and I have to say sometimes even I can't remember what the letters stand for. So I've chosen today to go with the acronyms that we see on the Draeger ventilators, because they're what we have at the Royal. And here are just a few, so I'll just spell them out so that we're all on the same page. CPAP is continuous positive airway pressure. NIV is non-invasive ventilation. PEEP is positive end expiratory pressure. BiPAP is biphasic positive airway pressure. Volume control, DC. APRV, airway pressure release ventilation. And you might see CPAP and BiPAP with ASB next to it, and that's assisted spontaneous breathing. And pressure support you might see with CPAP, and that's we're going to cover this stuff. Okay, so CPAP is one pressure throughout the respiratory cycle, as the name suggests, prevents airway collapse, reduces work of breathing. It can be used with a face mask to provide non-invasive support. Typically on ICU, we might use it in ventilator patients when we're weaning a patient from the ventilator, sort of at the latter end of their stay. And 5 to 8 centimeters of water is a common sort of amount of CPAP to use, and it can be titrated up. High flow nasal oxygen can provide some positive airway pressure through increasing pressure in the sort of nasopharynx and the cavity, around 3 centimeters of water, but I would not describe that as CPAP. It's just in a similar sort of family, may be used in similar circumstances to prevent airway collapse and reduce work of breathing. Non-invasive ventilation, so I've put a little picture of an IPI machine here, which is more commonly used on the ward. It's non-invasive, so face mask or hood, used in acute respiratory failure, most commonly in COPD. There's less evidence for its use in pulmonary edema caused by acute decompensated heart failure, and it's really not indicated in pneumonia. Inspiratory and expiratory pressures are set, and it's often quite protocolized for use outside ICU, and typically a protocol might start on relatively low pressures with an inspiratory pressure of 10 and an expiratory pressure of 4. And like I said, this is not really used commonly on intensive care and is often very protocolized. So next one was in the list was PEEP, which is positive end expiratory pressure. This is the name describes again, the pressure in the expiratory phase, and it's really a term reserved for invasive mechanical ventilation. Holds collapsing airways open and reduces repeated collapse and reinflation. And the graph here, if you can see it, the dashed line at the bottom is on a pressure time graph, and that demonstrates that you're going to have that baseline above atmospheric positive end expiratory pressure applied. BiPAP, 2 pressures, high and low, cycled by time. Volume varies, so your tidal volume is going to vary as your chest wall and lung compliance might vary. It's pretty much, I would say, our default setting on intensive care at the Royal. But drawbacks with it are that if you need to tightly control your CO2, for instance, in somebody who you're trying to instigate some neuroprotective measures, it may not provide you with enough tight control because of the variation in the chest wall and lung compliance, as I mentioned. And volume control. Most commonly, you're going to see this used in the operating theatre. I would say the default setting seems to be 500 mL by 12 breaths per minute with a PEEP of 5 and an FiO2 of 0.5. Patients need to be sufficiently sedated to really obtain respiratory drive and maybe have received some muscle relaxant as well. Allows tight control of CO2 and it's a mandatory mode. It's not going to be comfortable for someone to try and breathe on top of that. And APRV, which seems to have become more commonplace in its use over the last few years. You can see the screen next to the text there kind of demonstrates nicely how it's different to BiPAP. So you set like a P high, so high pressure, which might be around 20 to 30 centimeters of water, somewhere in that sort of ballpark, and a time high of about 5 seconds, and then a low pressure, so a P low, which might be 0, is usually 0, and a time low or T low of 0.5. So it cycles between quite a high pressure for a more prolonged period of time and a low pressure for a very short period of time. So you get almost continuous high pressure. And then it's time cycled to release to a low pressure, which is sort of infrequent and short. Spontaneous breathing's encouraged, and it facilitates this kind of open lung, which we're going to talk about that term in a bit, approach, and maximizes lung recruitment. There's a really good BJ education article, which is helpful to read. And there are some good YouTube videos about how to initiate APRV, troubleshooting, weaning from it, if you want to learn a little bit more, but it's outside the scope really of my brief talk today. And then the differences between the modes, so how they're initiated, what limits them, and how they're cycled. So volume control is initiated by time, so your set respiratory rate is going to be limited by volume. So once the ventilator has delivered that, say 500 mils of volume, it's going to stop and allow exhalation. The caveat to that, I would say, is that you can also put a pressure ceiling on this kind of mode of ventilation. So actually, if you say, OK, well, deliver me 500 mils, but don't exceed a pressure of 30 centimeters of water, and it gets to that 30 centimeters of water before the 500 mils is delivered, then it will stop. So you can protect to some degree using that. BiPAP is time initiated again, pressure limited this time. So once it reaches that inspiratory pressure that you've set, it will stop and you will be allowed to exhale, and that's time cycled. And APRV is a similar concept, really. And then pressure support is a supporting spontaneous breathing. So it's going to be initiated by flow. So the instigation of a breath, limited by pressure, because you're adding that supported pressure to a normal breath, and then cycled by flow as well. So the screen, when you first go onto ICU, you feel almost afraid to approach or touch the screen. because you do not understand what any of the numbers mean, what the graphs mean, and what will happen if you change stuff. So I would say don't be too worried, because you're probably not going to do too much damage by looking at it. But let's talk through what some of the things are. So this is a screen of BiPAP. And along the bottom are the controls. So your oxygen's the bottom left, and we're going to go through inspiratory pressure, respiratory rate, PEEP, and then there's some pressure support on the right there. Turn the big dial on the side and you confirm with clicking. Then for when you're sort of seeing the patient in the morning, you want to get an idea of numbers. So the peak inspiratory pressure is 22 there. Your minute volume is the next number down. Tidal volume displayed in litres. I'll prefer it to be in mils, about there. And then end tidal CO2 and your fraction of inspired oxygen. You've got 3 graphs which are shown here. They are pressure, flow and volume against time. They're all useful, but probably the flow at time is quite helpful if you're kind of troubleshooting, and we'll talk about that in a bit too. And then down the side there are some other sort of functions that you might look into as you get more used to the ventilator. So there's probably pretty accepted strategy for ventilating patients on intensive care, known as lung protective ventilation. And we're going to talk now about why we do that and how things have changed. So distension of the lungs using positive pressure ventilation is unphysiological, and it does cause harm. And that harm can be in the form of barotrauma through excessive pressure being applied, volutrauma through excessive distension, and through atelectrauma, which is the repetitive collapse and reinflation of the alveolar units. And this injury events result in a ventilator-associated lung injury. So this is lifted from Life in the Fast Lane, which is a really useful website for intensive care if you want to read about things in a fairly bite-sized way. So there are different types of ventilator-induced lung injury, and this is kind of saying, well, the sick lung is heterogeneous and it's not just one thing with one characteristic. So the dependent lung, the collapsed lung, is collapsed throughout the tidal ventilation despite high levels of PEEP, and it being collapsed causes a kind of chronic injury. Those intermediate parts of lung which are inflated during each breath or reinflated but collapse during exhalation, that cyclic collapse and re-expansion causes a shear injury, an atelectrauma. And those least dependent parts, those bits of the lung that are doing a lot of the legwork, are least dependent regions that remain inflated throughout tidal ventilation, but they can be overinflated if you're delivering high tidal volumes and have high plateau pressures on the ventilator. And you're going to potentially cause volutrauma and barotrauma to those parts of the lung. And all these mechanisms can increase cytokine release and contribute to the risk of multi-organ failure and mortality. So in 2000, a paper was published in the New England Journal of Medicine describing a comparison between ventilation with lower tidal volumes compared to traditional tidal volumes for acute lung injury in acute respiratory distress syndrome. And this was probably a game changer really in terms of how we ventilate patients on intensive care. And what I've put up here is their kind of protocol, which isn't exactly what we do now, but it gives you a bit of background. So the first part, setting up the ventilator, and they say calculate predicted body weight, and we use ideal body weight. And the reason for that is even if you are very big on the outside, your lungs are probably not proportionally sized. So we need to use an appropriate weight to titrate our ventilation. And they said, oh, select any ventilator mode and aim to achieve a tidal volume of 6 mils per kilo. And at that time, conventional ventilatory strategies probably were using between 10 and 15 mils per kilo of tidal volume, so a significant difference. And then set your respiratory rate to maintain an optimal minute ventilation, but not really an excessive respiratory rate of greater than 35 breaths per minute. And their target saturations were modest, between 88 and 95%. We don't really know what the optimum amount of oxygen saturation is in intensive care patients. I think we've just finished recruiting onto the UK ROC study at the Royal, and that had a kind of conventional and a slightly restrictive arm for targeting oxygen saturation. So perhaps we'll get a bit more information about what we should be aiming for with our saturations. And then they said increase the PEEP with increasing FiO2 according to a sliding scale. And that kind of ladder approach to increasing PEEP would use, but probably not to PEEP of 24. And then aim for a plateau pressure of less than 30 centimetres of water. And they said, well, if necessary, decrease the tidal volume. And if the plateau pressure is lower, then increase the tidal volume. And they said, OK, well, if you can't get the plateau pressure less than 30 centimetres of water, even if your tidal volume is only 4 mils per kilo and your pH is low, then you can allow that pressure to be higher. And if patients there were allowances for a bit of variation. And they were aiming for a pH between 7.3 and 7.45 and said, well, if it's less than 7.15, then give sodium bicarb. So the results of the study show that, well, the trial was stopped prematurely when the low tidal volume arm demonstrated a significant decrease in mortality. There were more ventilator-free days compared to the traditional tidal volume arm, and the absolute risk reduction of 9%, which they demonstrated, correlates with a number needed to treat of 11 patients in order to prevent 1 death. And I just wanted to put that into context. So statins, the number needed to treat is 138 people over 5 years to prevent 1 death, 49 people to prevent 1 cardiovascular disease event, and 155 people to prevent 1 stroke. So I think it was in this study, it was demonstrated to be a good intervention. The QR code at the bottom here is just a link to Wiki Journal Club, just for a more summary for you to look at if you so wish. So then these things maybe became enshrined into ICU practice. So 6 mils per kilo of ideal body weight tidal volume, plateau pressure limited to 30 centimetres of water, aim for the lowest FiO2 needed for a PO2 of greater than 8. I remember when I was an F2, I used to have a registrar who used to say 8 is great. And permissive hypercapnia, so tolerate elevated PaCO2 if the pH is greater than 7.25. So we're just, these rules about, or guidelines for PaCO2 and O2 are just to say, well, we don't really need to thrash the patient's lungs to get normal. We just need to get sort of good enough rather than perfect numbers, because the numbers don't mean a lot unless you can demonstrate benefit. So just something about spontaneous breathing. This is from the Draeger ventilator manual. So spontaneous breathing is what we do when we're well, and there's plenty of evidence to suggest that if you start getting your ventilated patients to breathe spontaneously, it has inherent advantages, and you can get improved alveolar recruitment and perfusion, and more homogeneous gas distribution, stable hemodynamics, and improved oxygenation. And this is a nice picture that kind of shows how reduced RB stress, reduced intrapulmonary shunt, increased cardiac outputs, all with reduced sedation and reduced mean pressures can improve perfusion, pulmonary perfusion, and you get improved recruitment through ventilating those basal lung segments, maintaining your respiratory drive, and less sedation. And in APRV, even when patients might be very hypoxic, it's good for them to breathe. So lots of modes might have the option to support spontaneous breaths as well as give mandatory breaths. And there's settings that you can adjust to optimize that. So what issues might I be presented with on intensive care? It's often a blood gas with a PO2 that's too low. So you need to think, what is too low? What's too low for this patient? Or a CO2 that's too high. What's too high? Or a patient that is fighting the ventilator, but I prefer asynchronous as a term because I don't think the patients are really fighting. And how should I approach this? So it's pretty same old ABC. Go and look at the patient, examine them, and really on intensive care, probably the trend is more important than the actual number, and whether it was sudden change or a gradual change. Think about what has just happened to them. Have they been rolled, a turn to put their the worst lung up? Have they had physio? Have they returned from theatre? Have they suddenly had a massive PE? Are they newly pyrexial? So try to put the result into context. And is this something that I should try and fix, or will it improve with time if I do nothing? And sometimes that is the answer. So for hypoxia, well, turn up the oxygen and call for help is probably never going to be wrong. And systematic approach to examining the patient. So examining the circuit from the ventilator to the patient or vice versa, whatever you might have been taught. Is something detached or blocked or trapped in a bed rail? I know it's happened before where the circuit's been trapped in the bed rail and the patient's actually ended up being extubated and re-intubated because of that. Is the ET tube patent? Is there an end-tidal CO2 trace? Breathing, well, examine them. Respiratory rate, saturations. Is it something you need to do something about now? Have they got a pneumothorax? Think about whether they've suddenly become wheezy. Cardiovascular system, are they hyper or hypotensive? What's their heart rate? Are they poorly perfused? Disability, are they making less respiratory effort than they were earlier? Are they exhausted because they've been on CPAP all day and they've been on the trachea mask all day and they need to go back onto CPAP overnight or CPAP pressure support overnight? Or are they inadequately ventilated? Are they too awake or too asleep? And then you could think, okay, well, is there something that I can do on the ventilator that might help? Can I improve things with that apart from just turning up the oxygen? And I'm just going to briefly touch on recruitment, which isn't perhaps the nice picture of this rainforest lungs is a bit misleading, but it's the concept of recruiting alveolar units for gas exchange, and the idea being that you will improve gas exchange, but that might be transient, and it's not necessarily a patient-focused outcome benefit for this, and you might just make things worse. So there are things you can do on the ventilator, but there are non-ventilator related things you can do to try and recruit up bits of lung. One of them is bronchoscopy if there's a collapsed segment, and try and remove a mucus plug, or if they've aspirated any sort of large pieces of debris, food debris that might have been aspirated. Chest physio is fantastic for helping to clear secretions and can make an absolutely massive difference to your ventilator parameters. Proning affects recruitment and has an evidence base for mortality benefit. And you can gradually increase the PEEP and wait and slowly see, because if the PEEP that you've got set at the moment is allowing that collapse and reinflation to happen, it would be more optimal to have the airways held open, and that's achieved by increasing PEEP. And you can do that in a kind of couple of centimeters of water and wait kind of approach. Or you can do something like an inspiratory hold where you increase the P high or the top pressure, and you just hold at that and try to reinflate the lung that way. But after any kind of recruitment maneuver, you probably need to increase the PEEP, because otherwise the lung will just return to its previous state. So what about elevated CO2? So do I need to do anything about it? That's the first question. So permissive hypercapnia, we allow and accept elevated PCO2 until the pH is compromised below 7.2. You might think, why is the CO2 high? So that goes back to the ABC approach. Sometimes if the HME filter is partially blocked, that might affect change. Are they wheezy or hyperexpanded? And what is the flow? So in this little graph down here, good. This is a flow graph where it says return to baseline, that's good. But where the expiratory flow is not returning to 0 before the next breath is initiated, if you keep on doing that, you will end up leaving more and more air behind in the lungs after every breath, to the point where the lungs become hyperexpanded, and that is going to then compromise both hemodynamics and gas exchange and needs to be acted upon. Or is it that so the patient has got a low respiratory drive, or they're very tired, as I said. Many things, are they hypermetabolic from a seizure or a temperature? It might be causing their CO2 to rise. So solutions, thought this graphic was quite nice. Just kind of shows there's a sweet spot where ventilation is optimal, and then you've kind of got a hyperventilation, hypoventilation, sort of insufficient zones around it. So again, is this a problem I need to fix? Is it a problem with hypoventilation? So if your PaCO2 is high, you could increase the respiratory rates, which will increase your minute volume, which will potentially increase CO2 clearance, but it might not solve the problem, because as well as all it will do, it may not increase the amount of time available for exhalation and may actually decrease your CO2 clearance. You could increase also the minute volume by increasing your tidal volume through increasing the actual set volume or increasing your inspiratory pressure. And you may want to think, if the patient has got asthma and they're in the acute phase, or COPD, is this gas trapping? And that occurs, as I said, in asthma and COPD patients need a longer expiratory time in their acute phase. They're still very wheezy. So that's where, instead of an inspiratory to expiratory ratio of sort of 1 to 2, we're looking at 1 to 3 or 1 to 4 seconds. And if you find yourself in that situation, you can detach the patient from the ventilator briefly, push on the chest wall to give a full exhalation, and then reattach them to the ventilator, and that might improve things. Or you can just increase the expiratory time and to allow a full exhalation and look for that flow, the flow to return to baseline before a new breath is initiated by the ventilator. And what about if they're asynchronous with the ventilator? Again, are they too awake, too asleep for the mode of choice? Have they got pain, agitation, delirium? Is there something increasing their respiratory drive above and beyond what the ventilator is delivering? And a bit of trial and error in thinking about those issues and whether they can be resolved. To find the optimal mode for that patient is probably the way to look at that. And deep sedation and paralysis should really be the option of last resort. In that situation, I think you should try and just troubleshoot really, and trial and error, and try and find what's going to work for that person at that point in their disease process. So in summary, it might seem confusing, but try to think of it simply. To start with, lung protective ventilatory strategy should be usual practice on intensive care. Issues with the ventilator, issues as with most things, try to be systematic, increase oxygen and ask for help, and think about the basics, and keenly await an expert talk next week. And some useful resources for now and ongoing. So Life in the Fast Lane is written by an Australian intensivist, maintained by them, and it's got a really broad range of stuff that can be useful for exam revision, as well as just looking stuff up quickly. E-learning for health has got some good modules. The Bottom Line has got excellent summaries of important papers within intensive care. And then YouTube or proprietary booklets supplied by ventilator manufacturers can be pretty helpful for understanding the unique kind of idiosyncrasies of that particular ventilator, or trying to learn a bit more about how they work or how you can troubleshoot or change stuff. I think that's it.
Thank you, Fran. It was quite useful, simple, but covered most of the topics. Doesn't the expert part next week that you are referring to, that's been postponed, so we have to wait for some more time.
Oh, it's been postponed. Oh, sorry, I've really been.
I think the expert is busy next week, so it'll be.
All right.
But at some other.
Sorry.
Any questions?
I was just kind of aiming for if you've just rotated onto intensive care, because I do think sometimes it's really hard to know where to start, and it's not always that accessible, especially if you're not an anaesthetic trainee. You just don't really know where to begin. So I was trying to just cover that basic ground.
Okay. Any questions from here? Yeah. I think one mistake which probably we all commit is looking at a blood gas, seeing a high PCO2, and then the reflex response is increasing the respiratory rate.
Yeah.
You mentioned that it doesn't work always.
No.